Next, please. And finally, to assess the economic burden, which is the aim 3, we will conduct a cross-sectional study to determine the economic burden of COVID-19 policies on transplant patients and their caregiver, focus on the cost effectiveness of early COVID therapeutic options, and identify cost effectiveness of Evishield as pre-exposure prophylaxis. So all of this will be done through questionnaires and data collection from patients' chart. And the questionnaire will include elements to answer the first aim, the second aim, and the third aim. So we'll have general demographic for patients, their transplant, their vaccination and outcome, and we'll also collect some other respiratory viruses to see that in comparison to COVID. For the mental health, we'll be using the PROMS, which is a patient-reported outcome measure. To assess physical and emotional quality of life. And then for the economic assessment through the questionnaire, there are different questions about education, income, ethno-cultural background, residence, etc. on both the transplant, the caregivers, and the family. And all of this information is going into a national online data platform. Next, please. And so this national online data platform was built by the Ottawa Method Center. And this online database can be accessed by patients, family members, and research staff via link and a QR code. And then the different questionnaires can be answered or entered at different times. So patients or family members can start, take a break, and then come back and answer more questions. Same for research and coordinators that are going to include some of the data collection, baseline data into the platform. Participant and research staff will get reminders on a regular basis. And then what we've heard from our patients is not everyone would like to use an online platform, and some of them would like to use paper form or even being called to answer some of those questions. So all of this is possible, and then someone from the team could include this on the online platform. Next, please. So what have we done to date? So 2023, I'm going to call it the startup year. So a lot of work has gone into ethics, contracts, and we've actually in Edmonton have started recruitment of adult SOT and their partners. So it's starting. 2024 will be continuing recruitment, data collection with analysis. And as you can see, there are different national platforms where those data and analysis will be presented to come up with more a research priority or more research questions. So that's what's nice. And this is how this platform is agile. And then what's important is through these national forums, we're going to get those information and then translate and mobilize this knowledge back to our participants. Next, please. So the second part is patient and partner priorities in 2022 and 2023, the proposed communication framework. Next, please. So our first CDTRP National Forum was conducted in March 25, 2022, and 30 individuals participated in this national forum. So we had patients, family, clinician, researchers, government, industry, economists, all of them met over Zoom. So March 2022, most of things were on Zoom. And we drew together some of the perspective from both lived experiences but also expert knowledge, and to try to identify some of the most emergent and urgent research questions. And it was clear that we had to enable an agile research response in face of this evolving pandemic back then. Next. And so from this first forum, some of the priority questions that came up was, what was the optimal treatment timing in transplant recipient for antiviral and monoclonal antibodies? What support are currently required to help transplant patients to return to normal life? And finally, what are the real costs, both qualitative and quantitative, of policies that impacted not only mental health, but quality of life and the return of normal for our transplant patients?
Of COVID-19 priority research questions and align the project's research goals with the community's priorities. Attending members of the June 2022 PFD Forum included 25 participants, comprising of clinicians, researchers, trainees, patient partners, public contributors, and CDTRP management team members. During this meeting, the top challenges experienced by transplant patients and their families during the pandemic included anxiety, fear, depression, information overload and a lack of tools, social isolation, government and healthcare policy, family impact, and disappointment and anger. The data in this slide reflects a snapshot of what patients or participants reported during the forum. It is important to note that we captured additional data exploring how patients felt during different phases of the pandemic compared to how they felt before the pandemic. During the first 3 months, 81% reported feeling worse. During a COVID wave, 90% reported feeling worse, and 45% reported feeling worse in June outside of the wave. Together, these results were utilized in the development of Treat COVID's research questions that Dima mentioned earlier. So the following year, at the June 2023 PFD Forum, 38 people participated in the session. Of the participants, approximately a third were patients and caregivers, almost half were clinicians, researchers, and trainees, and the remaining were CDTRP staff and public partners. A jam board brainstorming exercise engaged members to develop consensus on the most pressing knowledge gaps related to therapeutics, mental health, and well-being and economics in relation to COVID-19 and transplantation and their families. In yellow, you will see the group reflected of the caregiver working group, and in blue reflects the working group for transplant recipients. You will notice that more questions were raised from transplant working groups regarding COVID-19 treatments, while the caregiver working group raised more questions about mental health. The data in this slide but recipient data on the left is on the left and the caregiver on the right, just presented a bit different way. In this, it's highlighting the comparative of findings within group. You can see that these groups have different priorities, with 63% of recipients questions about COVID, while 50% of caregiver questions were on the mental health and wellness.
That brings us to the final slide before we get to go and put all the people in. So this one shows that as part of this project, it's very important that we have a clear communication strategy. So I have to see where Manuel is sitting and Rachel. And so the CDTRP team has been working closely together with us to figure out how we're going to communicate sort of the beginning. And today we're going to apply that communication strategy. So specifically to one challenge we have now, which is recruiting 2,590 or 2,600 effectively patients and partners and family members. So right now, that seems like an awful lot of people to recruit. However, with this group, we figure we can make it win. So participate. We're going to ask you then what ways we actually contact people, what methods do we have to figure out how to talk to people, how to engage them, how to actually get them to either fill in the questionnaires, get online and fill out the question or have us call them. And finally, is we want to if we tap into all of those, we can make a pretty good goal. And with a strong feeling that between people online and people here, we have hundreds and thousands of people. So we're going to use that particular framework for a couple things. Today, it's to help recruit patients into the study. Having that, we're going to also use this to make sure that we communicate the progress of the study to everybody that's involved. And thirdly, longer term, the big challenge here is we found this yesterday, people listening to those. We're talking to the I think somebody said drinking the Kool-Aid yesterday. We've already done this with Kool-Aid, right? The question is, how do we turn this into outcomes for that much broader set of patients and in fact clinicians that are working day and night, and you're all here and spending your time, you could be in clinic. So it's to make sure that we get to those outcomes. So we're using that framework to go forward. So because now I've taken we want to go straight into the exercise. So what we do now is have breakout sessions. And so most of the session, we want to get to this objective is if you want to facilitate the caregivers by identifying the patient strategies they can engage them on building confidence. People don't always want to participate in things. Maybe they're afraid, maybe they don't understand. We have to be clear as to what it is that would be the reason for someone to participate and spend an hour to fill in a questionnaire. And so we want to make sure we try and achieve those objectives through the study. So with that, we want to first go through and explain to the online teams, they're going to go off into 2 breakout sessions. So those are the things that we're going to try and answer. These are the questions. So each of the groups online will have a facilitator. So Dima and Margarita are the 2 facilitators. So there's going to be a split in half between all the people online into the 2 groups. And they're going to answer these questions. There's about 40 minutes total, probably about 37 minutes now. Barriers to recruitment. We want to know, why would transplant patients not enroll in these studies? One thing might be, hey, it takes an hour to fill out the darn form and I don't have time for this. I got to get back home. Whatever it is, right? There's a whole bunch of barriers. You'll know what they are because you'll have run into them in previous studies. So why would family members not enroll in this study? Dima had some experiences already where maybe the patient enrolled, but the family member did not. So let's look at family members as well. And also, why would researchers not support this recruitment? They are a vital part of this. When I get recruited into studies, I just happen to show up for clinic. I get there, I sit in the room, I wait, and then so I get an initial assessment done. Then somebody comes with a clipboard and says, hey, would you like to participate in a study? I might not even know about it. There's no other way I find out about these things. Well, maybe there's other ways we can get there. So why would researchers not support the recruitment? Why would they not want to go with the clipboard? It might be a painful process. Maybe there are other ways we can look at that. So let's identify the barriers so we can overcome them. Second question, why would they participate, right? What are the motivators? My motivator is I want to make sure that any future patient that has to go through this process, and it ain't fun for most of us, that if we can make it a little bit easier, wouldn't that be nice? And I happen to also have 2 daughters that have the same genetic mutation I have. They will have to go through this process. If it's a little easier for them 10 years, 20 years down the road, that's good. It's a simple motivator for me. Everyone has motivators. Third thing, so we're going to do that. And so the online groups are going to go cover these questions one after the other. Third one, what are ways we can communicate? What are methods we can use to get to these various patients and family members? So there are communication platforms, there are media channels, there's organizations, all kinds of groups, heart links, whatever it is, and it's different in every jurisdiction. We want to look across Canada, from Halifax to Vancouver. There are different groups everywhere. We want to identify all of them. Again, Manuel has made a good start. He's got a number of organizations. We want more. So Anybody, anything that you know, if somebody wants Heather Ross to do a TikTok, let's have Heather Ross do a TikTok, nothing, be creative. And so we want to find every way to do this on a mountain in Peru, probably. People to leverage in our network. So this is actually identifying names, individuals that we know. And again, this is where I'm going to pick on Sandra again. There are some stalwarts in our group, and most of the people are probably in this room or online. And so these are the people with the networks. We want names of people we can contact. So when we're done with this meeting today, we can turn it straight into action, because you saw the aggressive schedule that Dima showed us. We're trying to be done with that recruitment by sort of, Q2 next year. So we want to make sure we get there. So those are the credible sources, the influencers, all the people that we know. And that is it. So with that in mind, we are ready to send the 2 breakout teams away. We have some other exercises to do here in the classroom.
A few keeners in the room here. So we are going to start reporting back with the barrier side. So if you're going to, maybe we can see. Are you almost ready? You guys, team 1 over there, M1, you guys are ready, right? You're ready? You guys are ready? Okay. You ready? All right, so everyone's ready.
All right.
Can we start in the back corner over here, please, with barriers?
So yeah, we're going to start with the, oh boy, we're going to start with the negative stuff. We grouped them into participants and researchers, barriers. And the participant researchers, we could kind of group into the, some of just the barriers to time is probably the biggest issue. This is going to be an onerous survey. It's going to take a lot of time commitment. And it's going to even be more time if they get sick, which is like almost punishment for getting COVID. There's going to be potential for loss of interest as the 2 years go on, as people get less and less enthused about it. So so drop out there. And for that time, it's very low compensation. From what I understood, it's $15 for a minimum of 8 hours of work over 2 years, more if they get sick. So I think that would be, which kind of gets into the what's in it for me questions for the participants. And especially in this time of like COVID burnout, COVID fatigue, they might be sick of talking about COVID, thinking about COVID. That might bring up mental or emotional burdens, just even thinking about an illness that they might have had that they don't want to think about anymore. And just sick about talking about their sickness in general. This is a patient population that gets solicited for a lot of different activities, and to talk about their, pre-transplant, post-transplant, everything, that's going to be tough. And then as I know that I would be asking myself, what's the value to me and what's the social value? Is this a question that I find valuable? So if I was being solicited for this, they'd have to sell me on what's the value for me and my social group. For the researchers, getting contacts is going to be tough. Obviously if we recruit from their clinics, that could be valid or viable, sorry. But certainly if we were going to go, if someone came to Transplant Quebec and said, hey, could you give me a list of recipients? There's no way we would be able to do that for a variety of reasons around confidentiality. So, and I didn't mention, but there would be, it'd be tough for the patients to distinguish being solicited from spam, if it'd be through a telephone contact or an email contact. And that's also a challenger for the researchers. How do you frame this in a way that isn't just going to be, no way am I picking up this unknown number, no way am I responding to this unsolicited email. There's going to be overlapping recruitment for the researchers to look at. There's going to be coordination of self-enrollment versus enrollment in the clinic. So how do you make sure that if somebody has already self-enrolled, that then we're not soliciting to them again, which would just be, an annoyance to the participant. The time needed to manage all of those aspects is going to be a challenge for the researchers. So I guess those are the barriers that we hit on.
So we were a group of qualitative researchers, so you should probably, just to contextualize our answers. So we didn't split into patient population and the researcher population. This is just kind of global perspective. And some of the points are very similar to the preceding group. So our first barrier was the length of the questionnaire. 1 hour sounded a little bit excessive for a response to a questionnaire. Our second point was where the data were going. In terms of the just basically clarifying how the data would be used, that wasn't that needs to be clarified. We also, as qualitative researchers, saw the 3 aims, and we saw that all of the aims would be responded with the use of the questionnaires, and we were questioning whether there would be any value in having a qualitative component, whether the questionnaire actually captures the depth of the experience of the patient experience. Also, as the preceding group mentioned, participant and clinician burden. Clinicians are conducting a lot of research. Participants are solicited on many fronts, too many studies, and not clear how the participants would be benefiting from the study. And the example that we discussed was participating in perhaps more of a qualitative study where you're using arts-based methods, where the participants are actually generating some sort of benefit right there and at that moment in time. And then so our last points were, do the questions offer something that no one has asked before? So is there any novelty, I guess? And the research question needs to be more relevant, meaningful, when the intensity of the COVID pandemic has already kind of fizzled out. How can we change the questions in such a way that they would be more, perhaps more kind of, I guess, broad? And the last one was, how do you manage attrition? It's a fairly long study and people will naturally become sick. And yeah, as the preceding group mentioned, the compensation is perhaps not necessarily sufficient for the duration of the study. Thank you.
Has been said before. So, because we all agree with you know, the burden of questionnaires, the length, and so on. But I think one of the barriers that we identified that was not mentioned before is the COVID topic. I think in society, you know, people are tired of hearing COVID, so they want to move on from COVID. So I think, I'm not sure that patients will be happy to participate in something that they want to move on. Also, the electronic literacy. Some old patients have problem to fill online questionnaires. So maybe to think about a way that we were discussing, if the research assistant could fill the questionnaire online while the patient answer on the phone the questions or so on. And I think also for the physicians and the researchers, well, I'm just talking from my transplant program, and I think it's almost the same. You know, our clinics are overloaded. We just have enough time to, you know, to manage the medical condition. So we don't have time to talk about research projects. Same thing for transplant coordinators. So, and also to be sure that everyone is informed about this project. So it could be a barrier because there's a lot of turnover among the, you know, the nurses. So because patients will probably go to their nurses to ask about this research project. And if they're not informed, it could be a barrier. So just not informing people at the beginning when you launch the study, but to be sure that you keep them informed and that everyone is informed, all the new nurses and so on. So, yeah.
Okay, I know we need to be quick. So we, fortunately, we didn't do the separation between researchers and family members and recipients. So we're glad you focused on the research area because we focused on the family members and the recipients. So we divided into capacity, lack of motivation, access issues, project capacity, and trust. So under lack of motivation is the individuals knowing what the impact of contribution would be, get over here, frequency of interaction, that may be a barrier. COVID has been a controversial subject, and some people may have emotional trauma from what they went through during COVID, and as well perhaps medical trauma in actually having got sick and having to bring that issue with them. Capacity, people who are sick are less likely to have capacity to participate. It's a long study. We've already mentioned that. Language barriers, logistics and access to the research coordinator in each clinic, which Matt just referred to. Reliance on internet in some rural areas, and are we excluding certain populations because of access to technology? And then for project capacity, again, people have mentioned resources and who's doing the interviews. Is there a trust in who's doing the interviews? And then in the trust area, what are the issues around control of data? If somebody wants to pull out of the study, where does that data go? What's your confidence on how that's going to be treated or removed? Ensuring there's an avoidance of coercion to participate. An obligation, I feel like there's an obligation to participate. And stigma to disclose mental health issues during COVID. That comes with the baggage of COVID.
We're next here. We had the brighter side of this question, the motivators to patients and families. Thinking from the patient perspective, what we discussed that patients are really passionate about helping future transplant recipients and their caregivers, the message that I can help. Also the idea that this is not the only occasion during COVID that we should be mass communicating to patients to get them good information, that this matters on an ongoing basis. And so that as an outcome of the study would be a motivator. We talked about there was already a mental health problem in the transplant community before COVID, and patients are motivated. We need this research to help get funding and secure resources to help develop supports for patients that are needed at, on an ongoing basis as well. A practical motivator, having the research coordinator in the clinic doing recruitment wearing a mask was a facilitator that we discussed. From a family perspective, we discussed that family members would be motivated by seeing that this study would have the potential to help their loved one. And in terms of the time commitment, I can already see this on a postcard, the slogan, "You already donated your kidney to your loved one. What's another few hours of questionnaires?"
So we had a lot of the same things. One of them also was inclusion. So being part of something larger as a transplant recipient and family member, acknowledgement that you can give back to research as a patient or family. And then the long-term impacts of what this study could have and how that could benefit the patient population. Getting more general knowledge about COVID and understanding the risks, contributing to data and research. Similarly, a desire to give back to the transplant community and help inform and make changes. And you spoke about mental health as we did, the economics and therapeutics. And then also an honorarium, even though it's only $15, that is a motivator for people. You saw how many of us filled out that survey yesterday just for a $5 gift card. So that's also a motivator. On the research side, we talked about, with research, we want to make sure that we don't make the same mistakes that we've made again. So improving outcomes in the future, gathering information and data to inform research from the patient perspective as well. And then it's also required in the role of a researcher and that kind of lifelong urge to find more knowledge and gather more information.
Okay, we were in charge of some of the motivators also. You guys have talked about them some, and it's interesting how some of these speak to some of the barriers that were identified. And so we're talking about, we kind of grouped them together, with like motivators for the patients as well as the researchers. Some of them may apply more to researchers or patients. And so for number one, we talked about trying to make it better for future participants. Something that can motivate patients is that they know and that they can feel that whatever they do, whatever they're doing is actually improving the future participation of other patients. No, and also this is whatever they're doing is a chance to be heard. That they can express how what their experience has been, and hopefully that how that could help others in the future. At the same time, we talked about a chance to advance knowledge in science to inform future practice, and we thought of this as something that applies to both the patients, the family members, as well as researchers. And the compensation, I guess we heard about an honorarium, and if there is one already, it'd be interesting to look into whether there's a chance to even improve that. And one thing is that, say, for instance, if a patient has to go to a clinic and has to travel, whether the compensation is able to cover cost of travel or parking or whatever it is, and whether compensation also when it's in person is higher than when it's online, for instance. And recognition. I think it's neat when and Charles was sharing as a patient partner how if you participate in a study and you're recognized as a co-author, it's so much better. And then lastly, we talked about facilitated participation. So having someone who can guide you, who can help you to participate, I guess, doing whatever it is, a survey or something else. So these are what we talked about.
So we have about 7 minutes left. We started about 6 minutes behind. So we're going to change the exercise just a little bit. And so there are a lot of stickies there on the table. You've already started using. If you can use the smaller pens and stickies, the last two questions we were hoping to answer, and in 7 minutes, so this is going to be a high energy exercise. We have some space on the walls here, both sides, so you don't have to run to the other side. Where we have methods and people. So what we want to find out is any ideas that you have to reach transplant recipients or family members or caregivers in any way that you can. So communication platforms, locations of, institutions that have certain ways of doing, doesn't matter. We would like it across Canada. So wherever you have your particular set of skills or knowledge from would be great to add. So everybody would just write them on the stickies. If you have ideas about methods to reach recipients and family members, or if you have ideas of specific individuals you think are key to getting connected to that network. So this is you're on your own. You got your stickies. There should be lots of small pens there. So grab your stickies, and wherever they go, either in methods that you know of. Again, HeartLinks is a good example in Toronto. That might be a way. There might be others. There's a patient portal for the University Health Network. That might be a way to trigger some interest. Anything you can think of.
And places, subway and bus ads. I see dragon boat competitions, Facebook groups, foundations such as the Kidney Foundation and their newsletters. There's media, daily news show, an hour, Twitter, social media again, lots of social media networking, Transplant Center website, Facebook groups, posters in the waiting rooms with QR codes, transplant games, multiple languages. All right, Rienk, do you want to go over some of yours?
Yeah, we have a lot of the same ones, different organizations, interviews, again, social media, circulate media links. There's SPORE, I think that you talked about earlier, Sherrie. There's a number of organizations across there, Transplant Ambassador Program. So I'm going to focus on the people a little bit here. So there's one that says primary care physicians, and sometimes we forget they're closely connected still to their patients a lot of times. There's some peer support networks, clinicians, research assistants, the people in the room probably here. So Jamie Watt, and then there's Christina Haworam. I don't see Sandra's name up here, but I'll add it myself. That's fine. So again, the people in this room, I think, would be included in all the individuals. Do you have any other people there, specific people, Sherrie?
Now? Okay.
So Ryan Reynolds was definitely posted up here. I think that was a good one. Brenda Brown, president of the Canadian Transplant Association. There's Alan Vandercure. Definitely clinicians on social, Dr. Ross. And there's a lot of foundational groups, things like Gift of Life, over and over again, Canadian Living Association, Kidney Foundation, Hospice Networks, Transplant Games again. And then there's also nephrologists, clinicians. And I think that there's a lot of foundational stuff on here as far as research groups and foundations, patient Facebook groups. But I don't see a lot of patient identified. That's something we can look at as well. But definitely patients on Facebook groups. So identifying those people who that might be has access to those communities.
With that, we have 10 minutes. So we're hoping to bring in our online viewers and participants. So we have time for about 5 minutes. So if you could do, so Margarita and Dima, I think, are going to give us a quick summary of what was discussed in the online groups. So in about 2.5 minutes, Dima, you want to give it a shot? Is she still online?
Dima is
We
not
can start with
online.
Margarita. I know she's online. Margarita, could you do that in about 2.5 minutes or so?
Yes, I can. And Dima said that she had to leave, but Manuel is going to report for her. So I'm going to go first, I guess. So in terms of the first question, I'm going to be brief. Some of the reasons that were mentioned in our group were like people don't want to look at COVID anymore. They're over COVID. They don't want to talk about it. There's kind of a little bit of a resistance from physicians as well and healthcare providers to even support this topic being discussed. And some participants also mentioned that the healthcare system is overwhelmed. So healthcare professionals don't have time to dedicate to research, basically. In terms of the second question, many family members and patients mentioned that they would participate to help generate knowledge that can make things better for other people, other patients, other family members. So a very altruistic reasons, and to keep the conversation going on this topic that it's still very important and relevant to many patients and family members. And it would also, for some researchers also mentioned that they see this as a unique study, innovative study, so a unique opportunity to contribute to generate knowledge for in a unique and innovative study. In terms of the people and platforms, communication means and media locations, organizations, our group mentioned many of them. I'm not gonna mention them all, but they mentioned, website portals. The one theme that seemed to emerge was that regardless of the organization, the platform, and the mean that it's used, the engagement has to be simple, easy, accessible. So the way that we communicate and that we try to engage has to be, many mention a QR code that can be scanned and linked to a form that can easily be completed, but also maybe considering some paper and mail options for people who don't have the resources, or people who are maybe older or don't have access to internet, which we think it's readily accessible, but we do want to reach a diverse group and ensure representativeness. So so having some paper options for people who don't have access to internet is very important. In terms of who could be a credible person, some people were named, but some doctors were named and some famous people were named. But the idea that, again, the common theme that came up was a group of different different figures. So maybe a doctor, a physician, but also a family member, a patient, and again, ensure diversity and representation in terms of race, language, gender. So a diverse group that includes different figures so that it really shows that this is a collaborative effort, that this is a partnership among different people connected to, you know, the transplant journey in different ways. I hope I answered the question. Yes,
That's great.
good.
All right. So Manuel,
I
you
can
know
feel
you're
my-
going to have a lot of homework, and now you're on the feedback as well. So Manuel, where are
All
you?
good, all good, all good. Okay, with respect to question one, why would transplant recipients not enroll? Perhaps some concerns, maybe from previous experiences, that their voices might not be heard, or their thoughts, ideas not relevant. There is some discussion that some people just don't want to participate. They're not keen on sharing personal information under any circumstances, no matter how easy we make it, no matter the amount of follow-up that happens. Some folks just won't participate. Also, recognition of time constraints. It's long, it's demanding to fill out surveys and questionnaires, and especially when we're talking about patients who are in clinic, who are dealing with other health issues or various health issues. You know, trying to have them sit down and fill out a questionnaire can be daunting. Along that same theme, also the recognition that sometimes the language can be difficult to understand. So a suggestion of using lay language as best as possible in developing some of these materials. In terms of question two, family members and researchers, why they might not get involved. Just a recognition that it's harder for families and caregivers to get involved. I mean, at clinics, we have access to patients directly, of course, but there's no pathway to really connect with caregivers. We're relying on patients themselves to make that connection to caregivers. So a suggestion perhaps is make the researcher clear, make the research clear why it's important that we have caregivers and family members involved and as part of this process. There's also the idea that caregivers and family members might already feel heard because the patient is involved. So it's kind of this idea that, well, they're part of it, they're sharing all the perspectives, so I don't need to be involved as well. So again, a suggestion was to let, you know, we got to make a good, our communication has to show that by getting involved, you know, our participants are making a difference, kind of connecting them to what that personal gain is and how we can keep them engaged. Let them know that there is a sense of purpose coming out of these very difficult situations, and very practically giving updates on the study, no matter how small the update might seem, keeping people engaged and updated on what's happening. Probably over time, but question 3, what methods can we use to reach recipients across the country? I mean, we talked about some of the things that are happening, emails, being called, social media, but also knowing who to target and where. There's different platforms and each one targets a different audience. There's a suggestion here of really empowering the clinics, the coordinators, the transplant doctors to know about the study. So when the patient is in clinic, you know, they hand out a brochure, they have the information that they can hand out to patients, and then they can make a decision of whether the patient can make a decision whether they want to participate or not. As I've heard before, you know, transplant organizations, Kidney Foundation, Transplant Ambassador Program, for example, to not just go through CDTRP's channels, as that can be a little bit limiting. And in terms of communicating or engaging with patients across the country, suggestion of, you know, churches, for example, using patients themselves across different sites to champion this research. And there is a recognition of the need to reach out to specific organizations, community-based organizations that have that long-standing credibility and partnership with community members as we try to, you know, diversify our participants in this group. And with that, I will pause and throw it back to you, Rienk.
All right, thank you very much, Manuel. Give him a hand. So the hybrid part of this is done. So we just want to summarize. We have 1 minute, but if we could please take 2.5. So in terms of next steps, what we're going to do with all this information, thank you very, very much for producing all of that. We're going to take all this information, summarize it, and we're going to develop a number of actions out of it. So that's why I said, Manuel, we've got some homework because we'll have to take all this and it's going to go straight into, well, you see the little rocket ship there. We're going to launch this particular communication strategy as soon as we're out of the door here. So we're going to monitor and report on recruitment success. So next time you see us, we'll be reporting on how successful we've been to connect with everybody we need to connect with. And so we're going to use all that stuff from today for input. So with that, we have one more slide.
Yep. Okay, so again, thank you so much. So I just wanted to, on behalf of Rienk and I just want to tell you that, like, I know yesterday I said I use CDTRP as a brag book for patient collaboration and engagement, but it truly is. Rienk and I have not only been consultants, we've also been empowered by the community and of the researchers, clinicians, and the whole team to be able to shape and bring the patient voice in through our PFD forums and be able to really engage the community. So it's like an incredible feat to do, to be able to bring the community voice in. So it's actually incredible. And then on top of that, Rienk and I make decisions about where the project goes and presentations and the questions that need to be asked and those sort of things. So it is the highest level of patient partnership that I've ever experienced and read about. So I do thank you, because it's a real model in which we actually live and grow and play, and our health is attached to. So thank you so much for that. I also wanted to mention that we're looking at potentially advancing patient collaboration and potentially using an advisory group. So if basically, an advisor group is a group of diverse individuals passionate to get involved in health and health research. So this study particularly, treat COVID, as you've seen, it has a lot of different sub-projects. So we're looking at getting a lot of feedback from our community and making sure we broaden that voice. And we actually capture the community, because the more people we can engage, the more robust and enriching the information will be to shape this project.